My name is Brahim Badradoza, and this is my DPP, Dr. Saad Tabassum.
Hello.
Hi. So today we'll be carrying out a case-based discussion about a patient I'll be referring to as Arthur, in line with confidentiality requirements. So just a little bit of a brief history about Arthur. So Arthur was an 80-year-old gentleman admitted with 5-day history of productive cough with rusty coloured sputum, pleuritic chest pain, worsening breathlessness, and notable decline in his mobility as well. He is normally independent gentleman who walks his dog daily, and his son has also reported that Arthur has been a bit confused and a bit of there's been delirium as well.
Right.
His background also includes stage 3 COPD and heart failure with preserved ejection fraction, and his regular medication includes ramipril 5 mg once a day, furosemide 40 mg once a day, salbutamol inhaler when required, and tiotropium as well. And that's
All right. So, would you tell me how do you structure your history taking with Arthur?
Yeah, so the way that I was structuring my history there, I used a 7-part history taking approach, which included a presenting complaint, history of presenting complaint, past medical history, drug history, social history, family history, and review of systems. So for Arthur's presentation, we primarily focused on respiratory issues, so concentrated heavily on the history of presenting complaint. So for the chest pain and cough, I used the framework Socrates to characterize the symptoms, so including pleuritic nature of the chest pain, progression of the productive cough, and associated breathlessness, so all the symptoms basically. And then also did a review of systems, explored alternative causes of his symptoms. Obviously, given his background of heart failure, specifically screened for features of fluid overload, included orthopnea, worsening peripheral edema, and palpitations. Obviously, Arthur denied all 3 of these symptoms, which made decompensated heart failure less likely as the primary diagnosis.
Right.
So Arthur also reported 5 days of poor oral intake and significantly reduced urine output. So this immediately raised concerns about dehydration, possible AKI. So I prioritized renal blood tests alongside inflammatory markers as well. Arthur's son was present throughout the history taken as well, so provided important collateral history regarding his increased confusion and reduced ability to manage independently at home as well. And so yeah.
All right. So, what consultation model did you use and why?
So I used the Calgary-Cambridge consultation model to structure the consultation. So in an acute ward environment, there is often a tendency to focus purely on biomedical aspects, which would help reach a diagnosis quickly, initiate treatment rapidly, and prioritize urgent clinical tasks. However, Arthur was visibly anxious and distressed about his breathlessness, so I felt it was equally important to address the patient's perspective alongside the clinical assessment. So the framework helps to establish a rapport with the patient, explore Arthur's concerns, involve Arthur's son as well appropriately, agree on a shared agenda, and maintain patient-centered communication while still gathering clinical information.
Okay.
And yeah.
So, tell me about how did you distinguish community-acquired pneumonia from a COPD exacerbation?
So the key distinction was between focal and diffuse examination findings. So on auscultation, Arthur had coarse crackles localized to the left lower lobe and dullness to percussion in the same area. These findings were consistent with consolidation caused by inflammatory exudate filling of the alveoli, which alters basically sound transmission through the lung. In comparison, a COPD exacerbation would more typically present with diffuse bilateral expiratories, a generalized airway obstruction, rather than focal signs. Also, Arthur had other symptoms such as fever, 38.1 degrees, rusty sputum, classically associated with streptococcus pneumonia, acute delirium as well, and focal left lower lobe signs. So I treated the delirium as a red flag from the onset because new confusion in an elderly patient specifically, should never be dismissed or simply attributed just to dementia. Altogether, the clinical picture strongly supported CAP rather than isolated COPD exacerbation.
That's good.
Mm-hmm.
So, could the basal crackles have been explained by the heart failure?
So yes, decompensated heart failure was an important differential diagnosis, but it can present with basal crackles and dyspnea as well. So specifically assessed for other signs, so fluid overload, including raised jugular venous pressure, worsening peripheral edema, and orthopnea as well. Arthur had none of these features, and his blood pressure was also quite low at 102/64, which was less consistent with acute fluid overload. So the overall clinical picture was more suggestive of an infection because he had a fever, delirium, unilateral focal chest signs, and evidence of systemic sepsis. In contrast, heart failure would more commonly produce bilateral pulmonary findings rather than focal left lobe changes. So I requested a chest x-ray, confirm the diagnosis, and distinguish CAP from heart failure, COPD changes, or other pathology such as malignancy. Next bit I was going to talk to you about as well as the AKI staging as well.
Yeah.
So before making any prescribing decisions, firstly you need to fully understand Arthur's renal function, as this would directly determine all dose adjustments. So his creatinine had increased quite significantly in this case. So it was at base at 90 micromoles per litre, and then it shot up to 248. So this EGFR that we calculated was 22 mils per minute. So this represents more than doubling of the creatinine basically. Therefore, this, according to the KDIGO 2012 criteria for stage 2 AKI. So I considered the likely etiology and concluded this was the most consistent with prerenal AKI due to sepsis-related vasodilation, leading to reduced renal perfusion pressure, and obviously 5 days of poor oral fluid intake and ongoing contribution from his regular medication.
All right. So, what you say, which medications were contributing and what did you do about them?
So the contributing medicines I was thinking about were the ramipril, which is an ACE inhibitor, and furosemide loop diuretics. So how they contributed, so you ask, so ramipril reduced compensatory efferent arterial constriction, worsening renal perfusion in hyperperfusion, and furosemide increased volume depletion, further reducing renal blood flow as well. So the action we took was both ramipril and furosemide were withheld immediately. And then there was some education also provided to the patient and patient's son, so explaining the sick day rules, advised temporary stopping of these medications, and explain why we did that in patient-friendly language, and during any future dehydrating illnesses to prevent reoccurrences, basically.
Yeah. Okay. Could you walk me through your antibiotic selection for Arthur?
Yeah, of course. So I followed the NICE guidelines, which recommended dual therapy for severe inpatient CAP. So a beta-lactam plus macrolide. So for Arthur's case, his CURB-65 score came back as 3 based on his confusion, age of 65, and urea as well, which is quite high, with AKI, confirming severe pneumonia and needing for IV therapy. So I obtained blood and sputum cultures before antibiotics to support antimicrobial stewardship and further de-escalation. But we weren't waiting for the sputums to come back. We were just going to start with the IV comoxiclav first. So we started with IV comoxiclav for broad beta-lactam cover. We had to adjust the dose due to his AKI. So it was a 1.2 grams loading dose with a 600 milligrams every 12 hours. And then the plan was to step down to oral comoxiclav 625 milligrams twice a day, once clinically improving. After 48 to 72 hours. And then also we chose clarithromycin to provide atypical cover, particularly for my mycoplasma pneumonia. So it acts by inhibiting protein synthesis at the 50S ribosomal subunit. So my main concerns with this was the QT prolongation, specifically for this patient, especially due to AKI. It reduces clearance, increasing drug accumulation, and then also the heart failure can increase baseline arrhythmia risk as well. So this increases the risk of torso at the point. To manage this, I reduced the dose to 250 milligrams twice a day for 5 days in line with the BNF. Okay.
So tell me, how did you manage his fluid balance given his history of heart failure?
Heart failure. Yeah, so this is a key clinical balance between two competing risks. So treating pre-renal AKI, which required cautious IV fluid resuscitation to restore renal perfusion, and avoiding fluid overload as well in heart failure. So we need to balance this somehow, where reduced ventricular compliance increases the risk of pulmonary edema. So this wasn't in my scope of practice, so I had to escalate this to the on-call registrar at the time, using SBAR to agree a safe and structured plan. So we implemented cautious rate-controlled IV fluid administration, strict hourly fluid balance monitoring, and target urine output of just more than 0.5 mils per kg per hour. And then also inform the nurses as well, just to escalate it if there's any triggers of any new bilateral crepitation, rising respiratory rate, increasing oxygen requirement as well, and then repeat monitoring as well. Include a daily use and ease, creatinine, and then use 2 observations as well every 4 hours to track sepsis. And then yeah, that's it.
All right. So just mind was, how did Arthur delirium affect your prescribing process?
So Arthur's delirium directly affected his capacity to engage in the consultation under the Mental Capacity Act 2005, so completed 2-stage capacity assessment. At the time, Arthur was unable to understand the relevant information, retain it, and weigh up the decisions about treatment. So this meant his autonomy was temporarily impaired in line with the Beauchamp and Childress principle of autonomy. So I therefore proceeded with a best interest decision involving his son, explaining the CAP diagnosis and treatment plan, justified the IV antibiotics and dual therapy, and explained withholding ramipril and furosemide due to harm. So this reflected the beneficence, so treating infection, non-maleficence, stopping harmful nephrotoxins, and I continued to involve Arthur as much as possible using simple explanations and comfort checks as well. And just about a little bit about communication documentation as well, and ethics. So ensured ongoing patient-centered care by explaining treatment in accessible language, which was fine anyway for this patient speaking English. Keeping Arthur involved despite fluctuating capacity, educating his son on a treatment plan and sick day rules for discharge, and then reflection capacity was assessed appropriately, and then however documentation was retrospectively rather than controversially. And this is one of the limitations, as GPHC standard requires timely and accurate record keeping. And then also justice was demonstrated throughout the consultation as well. So early IV to oral switch, once improving, presented IV capacity and nursing timing for more unwell patients, and aligned with antimicrobial stewardship and NICE guidance. And yeah, that's it.
Yeah.
The last
so
one.
Tell me, was there a moment in this case where you felt it was moving beyond your scope of practice?
Yeah, so it's important to be clear about that. If Arthur had deteriorated into respiratory failure, requiring NIV or ICU level care, this would have been way outside my practice. So decision regarding NIV, CPAP, or critical care management sit with respiratory physicians, critical care teams, consultants, etc. In line with GPHC standards, remained within my competence, recognizing that working within scope is essential to safe prescribing, and escalation is a core clinical responsibility, not a limitation. And yeah, that's it.
So, tell me about what learning needs did this case identify for you?
So this case strengthened my confidence in managing AKI, including identifying and withholding nephrotoxic medication, renal dose adjustments, initiating cautious fluid resuscitation with the help of the on-call registrar, setting appropriate monitoring and escalation parameters to the nurses. Also, there's been a few learning gaps as well, so safe timing and criteria for restricting ramipril and furosemide post-AKI, when to do this, particularly in patients with heart failure as well and recurrent admissions. And this clinically quite important, as these patients often require careful long-term optimization. So that is my case-based discussion done. Covers all the key elements that we've spoken about today.
Exactly.
all decisions were made in line with the NICE guidance, GPHC standards, antimicrobial stewardships, and the help of a consultant and on-call registrar as well, with appropriate escalation and MDT involvement throughout. And that concludes my CBD.